And now we'll kick off the first official session of today's conference, Behind the Scenes of a Brain Tumor Board. This will consist of a multidisciplinary panel of expert clinicians who will simulate the review of brain tumor cases to determine the best course of treatment for patients. The goal of the session is to show you how treatment decisions truly involve teamwork among physicians to ensure that we're giving the best care possible for our patients and how those conversations are had. I'm going to introduce everyone to come up to the stage. First, I'd like to introduce our moderator for this session, Dr. Mark Gilbert from the NIH, a neuro-oncologist. Our panelists include our neuro-oncologist for the panel, Dr. Akanksha Sharma, who's at Sutter Health. Our neurosurgeon for the panelists is Dr. Michael Lim, who's the chair of neurosurgery at Stanford University. Our radiation oncologist is Helen Shih, a radiation oncologist at Mass General Hospital in Boston. Our neuropathologist is Matija Snuderl from NYU Langone Health. Our radiologist is Javier Villanueva-Meyer from the University of California, San Francisco. And our neuro-oncology nurse navigator is Jenny Lynn Iwalu from the Brain Tumor Network.
Thank you so much. It is certainly a great honor to be moderating this session. Reminiscing, I realized I gave my first talk at the ABTA in 1997. I was 12. So, all kidding aside, actually my daughter, who was 11, was in the audience, and she had just written a report for school on brain tumors. I don't know where she got that idea. And her final paragraph talked about how much hope she had because people like her father were in the field. And I presented that. She was in the audience, and I got a clap. She got a standing ovation. So, tough act to follow. This is my favorite session. As you may have surmised, I have retired, but I came back because I was asked, and it really is such a tremendous opportunity for all of you to understand what we go through as physicians taking care of folks with brain tumors to make sure that the best decisions are made. And what these guys don't realize is that I'm going to go a little off script. And that's what happens, right? What we're looking for is discussion and consensus building. And so you can hear the controversy, the discussions, the importance of really getting everybody's opinion coming to a consensus. And we're so fortunate to have such a fantastic panel of colleagues. It's a small field, so I kind of know everybody. I was in the field for 38 years, so you would hope I'd know everybody. And we will actually go through 2 cases, and with each we will get input from all of our esteemed colleagues. So these are the disclosures. And just to quickly review, a neuro-oncologist, typically it's either a neurologist or a medical oncologist who's received specialized training in the treatment of patients with brain tumors. So medical therapy, the neurosurgeon, a surgical treatment, radiation oncologist, radiation therapy. The neuropathologist is a specialized pathologist who focused on diseases of the central nervous system, also peripheral nervous system. Radiologist, of course, interprets imaging, but I would say that to get the best care, it should be a neuroradiologist. And we're very fortunate to have actually one of the top neuroradiologists in the country. And then the neuro-oncology nurse navigator, right? So to integrate all of this care to make sure that the patients get the optimal treatment, the logistics, the family support, et cetera, this person is incredibly important. And of course, the supportive care services, which we will talk about a little bit to date also. So first case. So a 61-year-old right-handed man presents with confusion and headache. Symptoms started about 2 months ago, mild daily headaches. Now they're severe and intolerable. 2 weeks prior to this, family noted some confusion, forgetfulness. His past history, not surprisingly, hypertension and prediabetes, quite common. And the patient is retired from law enforcement, newly divorced, lives alone, no children. Home is about 45 minutes away from the medical facility. And his family history remarkable, just for a father who died of colon cancer. So with this, of course, seen in an emergency facility with that history, an image would be done, and I'll ask Dr. Villanueva to not only describe what we see here, but also to give you all an overview of imaging, MR being the magnetic resonance imaging being the most common, just to give a quick overview so your interpretation will be more complete.
Thank you, Mark. As Mark just noted, MR imaging is the mainstay for assessing the status of tumors in the brain, in the spine. The bread and butter sequences, which are the types of images that we acquire, are T1 post-contrast, which is what you're seeing here on the screen, and T2 in a particular type of T2 image. It's called a T2 flare image, which you may have heard of. And we look at those two as the main sets of images to help us understand the characteristics of a tumor, where a tumor may be. But as you can all imagine, the story doesn't stop there. There's additional images that are also acquired. Here we're going to focus on some of the more basic things initially, and then we'll maybe fold into the discussion some of those other sequences. In this patient's case, what we're seeing here, as I mentioned earlier, this is a T1 post-contrast image. It's an axial view, meaning it's a view you're looking from the top down or from the bottom up. We're sort of at the level of the ventricles, as you can see. And in imaging, when we're describing findings, we like to mix things up. And so the right side of the screen is actually the left side of the body, and the left side of the screen is the right side of the body. So in this patient's case, we're seeing a tumor that's posteriorly along the right-hand side, involving kind of the temporal and maybe inferior parietal areas. You can see there's some contrast enhancement. That's that bright signal, or the bright area on the back part on your left-hand side of the screen, but the right-hand side of the patient. And inside of that, we see some lack of contrast enhancement. That's what we would describe as necrosis. I'm only showing you a T1 post-contrast image here, so you can't see the T2 flare, but the areas that are dark, that are at the periphery outside of that represents edema or swelling related to the tumor. What we're seeing here would be described as something that looks aggressive. This looks like a high-grade glioma very clearly. One of the things that I'm doing is I'm looking at these. The most critical thing, I think, is really to identify other sites of disease. What we're going to, this is easy to see, relatively easy to identify, but where you really want to make sure that what you're not missing are additional sites of disease. So we're looking both on this T1 post-contrast as well as on the T2 flare images to look for other sites of disease. But here we have what looks like a high-grade glioma.
Great, thank you.
Can I just ask him a quick question?
Yeah,
So
please.
a lot of patients who might be going to the community hospital will get a CT with contrast. Why is that not enough?
Yeah, that's a fantastic question. So a CT with contrast has several limitations. Probably the first limitation is, or the primary limitation is really the spatial resolution that you can, I don't have a way to compare and contrast it here, but here you see images that are at a tissue resolution of about 1 millimeter. So very, very, very thin, very tiny. With a CT, you're like 5 times that. So the soft tissue you're not seeing as well. Also, with the CT, you really only get one set of images, even if it is with contrast, right? So while you may see contrast enhancement in the CT the same way you see here, you don't get an opportunity to really understand what's going on outside of the contrast enhancement. So it's really the resolution and then the multitude of additional pieces of information that come from the other sequences.
Great,
Yeah.
great question. Okay, so this is noted. Obviously, an intervention is necessary, and we'll ask, actually, Dr. Lim what he sees and how we would approach it, and what goes through the mind of a neurosurgeon when approaching a situation like this.
So at this point, it's the start of a patient's journey. They get diagnosed, and this person's life has just been turned upside down. And there's two scenarios that happen in this situation. Sometimes the patient is seen in an emergency department, and maybe a neuro-oncologist is consulted, and then the patient presents to the tumor board. Or more often than not, the patient actually sees the neurosurgeon first. And in both situations, when we assess these films, when I have my first conversation with the patient and we say, this may be cancer, I say, we have to be clear about our goals. And our goals are two things: survival and quality of life. And I say, from this point on in your journey, you have those two questions that you need to ask at every decision point from this point forward. And when I assess this film, if we're in tumor board, the question that I have is, can I get it out? And it is important, because if we can get what we call a extent of resection, if you can get a lot of this out, you can potentially improve quality of life and survival. The other goal is diagnosis. And if we're in a tumor board, the third question is clinical trials, if the patient has potential clinical trials. At this point in a person's journey, in looking at this person's scan, in my assessment, the only thing, in addition to the headaches, which I think is coming from the pressure, I would be checking what I call visual fields to check if they have loss of peripheral vision. If they do, this is probably something where I think you can get a gross total resection. When I say gross total resection, you can probably get all of that enhancing area out. We have done lots of research in the field for this. And what I tell people is, if you can get 80% or more of this mass out, we can positively affect survival. We can give you better chances for survival and living longer. If you go, though, and you're aggressive, and we cause a deficit, we cause you to become weak, or you lose speech, all that benefit is lost. So it's a very important decision point for your care. Extent of resection and not causing a deficit and getting you the diagnosis. Those are the goals. And in this situation, where it's located, it is away from critical structures like what we call the motor, which is to move your arm and legs, and it is in the non-dominant hemisphere. And in this case, the conversation I would be having with this gentleman would be to get it all out, because I think that we can achieve better chances for survival and getting the diagnosis for that patient.
So Dr. Lim, you talked about non-dominant hemisphere, and if people remember, the history said that he was a 61-year-old right-handed man. How significant is that?
Great point. So I should qualify. So when I say non-dominant, we usually say dominant hemisphere is the left hemisphere because speech is there. I probably should be a little clear. In this situation, it's away from, even if the speech was on the other side of this patient, it's far away from the speech area. But because it's in the non-dominant hemisphere, and because this is a right-handed individual, they have a 90% chance of having speech on the left side.
So really an important point.
Yeah.
And if you would tell this person, with your surgical skill, which is extraordinary, you would be able to get all of the visual tumor out. What aids would you use in the operating room to do that?
Perfect segue. I was going to get into that. And so I think I always tell my patients I'm humbled by God every day in my life. Even though I think I can get it all out, we can leave nooks and crannies behind. Even in the best academic centers, sometimes as much as 30% of the time we could leave a little bit behind, which is why at least getting to the 80% is a critical threshold. there are things, adjuncts that we can use. As an example, there's a dye that we can give. A patient takes a medicine about 6 hours before, and then this dye appears when we use a microscope, and literally the tumor looks pink. And what I like to use that because there have been times when I've been surprised, and I find a little bit more than we have. We also have really amazing imaging tools. We call it neuronavigation. And it is essentially GPS for the brain. And you can put this little probe in, or the microscope shows you where you are in real time in a person's head as you're taking out the tumor. The problem with that is that as you take out the tumor, the brain starts to sag, and that navigation becomes less accurate. And then in certain situations where we'll talk on the next case, we have something called intraoperative MRIs, where we can actually take MRIs in the middle of the surgery to try to make sure that we ensure getting to that threshold.
Great.
And then I'll talk on the next case. In certain situations, we keep people awake to try to make sure we don't induce deficits, because that's also the important part.
Fantastic. So I'll ask Javier. So this is what the postoperative scan looked like. This is not Dr. Lim's handiwork, by the way. But
Yeah,
fire away.
So what we're seeing here, this is the same type of image as we saw on the first preoperative time of diagnosis scan just a couple slides ago. And what we're looking at when we're reviewing these images is we're scrutinizing to understand, as Dr. Lim just mentioned, the extent of resection. So we're looking for how much of that contrast enhancement was removed, and how much of the maybe non-enhancing components of the lesion, if we're talking about glioma, which this is what we're presuming this to be, we're also looking for that as well. The challenges we have are that some of the changes that happen from the surgery can manifest as contrast enhancement. So it's absolutely critical that in these patients we get imaging within 48 hours of the surgery before those changes start to manifest on imaging. And so these can be very tricky, very tough scans to interpret, and I think that kind of speaks a little bit to your point, Mark, about the importance of having a neuroradiologist evaluate these images. But what I'm seeing here, this ends up being what we would call a gross total resection of the contrast-enhancing tumor. I know that there's some areas that look a little bit bright, but some of that represents blood products, some of it represents some blood vessels.
Great. Thank you so much. So we now have a gross total resection. And again, as Dr. Lim so eloquently put it, the idea is to optimize every step. So step one is optimal. Now we have tumor tissue and gross total resection. You can see uneventful postoperative course, walking the next day, headaches resolved on some dexamethasone, and although no history of seizure, was sent home on a seizure medication and is set up to follow up with specialists in 2 weeks. And the tumor board is going to talk about pathology. So since we're all in the tumor board, let's talk about pathology. Dr. Snuderl.
Okay, so I'm a pathologist, and pathologists are sort of like the invisible actors in this play. I would place a good bet that most of you have never seen a pathologist before, and I'm the first pathologist you can see. So I'm here, I'm real. And the role of a pathologist is to determine two things. First of all is that the impression that clinicians had from the imaging is indeed correct, that what we are dealing with is a brain tumor. It is a primary brain tumor, not a metastatic brain tumor. It is not an inflammation. It's not an infection or anything else. The second is to determine the actual diagnosis, what kind of a brain tumor it is, and then to determine what we call biomarkers. Those are sort of like signs that will tell us where is this patient most likely going with his or her journey in terms of future treatment or clinical trials. What you see in the top left are two purple and pink images that probably look very confusing of you, but this is a tissue that gets taken out of a brain, processed, fixed, put in a wax box, and then sliced extremely, extremely thinly, like in a deli, if you imagine like a very, very thin slices. And those slices are so thin, we can then stain them with a stain called hematoxylin eosin, which makes the tumor tissue pink and purple. And what it does is that hematoxylin stains everything what is acidic blue. So nuclei of cells, because they are full of DNA, will stain blue. And that's how we can tell the morphology of the cells. We can count the cells are proliferating or not. And everything else will stain pink. And that pink stain is coming from a stain called eosin, which is actually extracted from a tree bark. So now you're thinking, wow, that's a very old-fashioned technology. These guys are doing it the old way. And it's true. This technology has been around for more than 150 years, and it's still the mainstay of diagnostics. What we see on the top left is big, prominent cells. You can see in the middle, I'm not sure, Mark, if you can point to it, a mitotic figure telling us that these cells are proliferating, they are multiplying, if you will. And on the right, we see proliferation of blood vessels. And that is what gave on imaging the impression of that enhancement appreciated by neuroradiology. Well, you look at this and you're like, not much has changed if they're using a tree bark to stain the tumor. But in contrary, the research and many, many studies have helped us to really classify these tumors in a great detail. So what we do next is we use the same tissue that we looked under the microscope, and we perform what is called molecular testing. And for the simplicity, just on the right side, you can see we can analyze all the chromosomes in the tumor. We can see what are the changes in the tumor. We can see where the red arrow is. There's amplification of the gene called EGFR, which is very common in a glioblastoma. And what the blue line is, we can see there is a loss of a gene called CDKN2A, also very frequent. So we can now, with a great detail, determine what drives this tumor to help our clinical colleagues to move forward. On the right side, you can see MGMT prediction, which is a marker that is probably familiar to many of you, and it is absolutely critical biomarker to predict the next steps in patient's journey. And what has emerged in the last few years is a detailed precision medicine map where we can now tell mutations on every single gene that drives the glioblastoma, and you see that on the bottom left. So after I'm done with this analysis, I can tell my clinical colleagues this is a glioblastoma. It is a WHO grade 4. It is negative for IDH mutations, but it is hypermethylated for MGMT and has a third promoter mutation, as well as EGFR amplification and CDKN2 deletion. Critical biomarkers to help guide our future discussion. Thank you.
So, fantastic overview. I hope everybody took notes. So, you pointed out that the pathology, the classic pathology, 150 years. Probably the last 15 years, molecular diagnostics have come into the fore. Is it adequate to just do histopathology, or do you feel that every brain tumor specimen should undergo molecular testing?
That's a great question, and simple and resounding answer is no. The simple histopathology, although it is important and critical, it still tells us we're dealing with a glioblastoma. It tells us it's not anything else, it's not an infection. It cannot be sufficient for diagnostics. All those molecular markers that I am showing you here, and I know it's a lot and probably a lot to digest, but the bottom line really should be we now know so much about these tumors and how they behave, and this information is absolutely critical for the management. I always start with saying that every journey starts with a correct diagnosis, and biomarkers are absolutely required for correct diagnosis.
Yeah. So it should be the national and probably international standard of care that molecular testing be done on every brain tumor. And actually, what's interesting, even for tumors that look like glioblastoma, it's been estimated between 5 and 8% of them actually turn out to be a different cancer when you do the molecular testing. And then, of course, when you get to the less common brain tumors, that number of misdiagnosis based on pathology goes up. So I want to emphasize that point, and we're very fortunate to have one of the top neuropathologists joining us today. All right, so we now know the tumor has had the optimal surgery. We have a fantastic idea of its biology through this molecular testing, and now it becomes treatment decision time, which is really where the tumor board excels. and we're very fortunate to have some real experts. So I'm going to ask Dr. Sharma to go ahead and start the discussion as the neuro-oncologist who very frequently becomes the captain of the ship.
Yeah, so we work closely with our neurosurgery colleagues from this point onwards to make sure that we take over the care of the patient, become the captain of the ship, but we also want to make sure we coordinate care with our radiation oncologist. And so we'll talk here about the members of the team and how important that is. I want to add, just going back to the last point, most community hospital systems in the US are still not sending genetic sequencing. So we are trying to make more of an effort on that, but that is a very, very key part that I need to be able to decide your plan and also to be able to figure out, are there any clinical trials that you could do? And so this next step really becomes important in terms of understanding what are the treatment options. Are we going to do what we call standard of care, which is radiation and chemotherapy, oral chemotherapy, or is there a novel treatment trial that you could enter? In brain tumors, patients who do a clinical trial overall, even regardless of the trial and regardless of if it works or not, actually do better. So that's in cancer in general, but just being on a clinical trial improves your overall survival. And so we want to get people on a trial. We also want to, of course, help the science, but especially if you have a specific mutation, we may be able to match you to a trial that really works for you, and we want to not lose that opportunity. And the sooner we know it, the better it is. So the testing takes about, in most other hospitals where it's not an academic center, takes about 3 weeks to come back. And so we want to make sure it's sent as soon as possible, and then at that tumor board, we're talking and trying to make a quick decision on radiation therapy and on chemotherapy. And so I think we're going to talk next about radiation. So these are the questions I just discussed. So the role of the neuro-oncology team I've already mentioned. We're really going to work closely with everybody to make sure that we follow you and re-involve neurosurgery or anybody else that needs to be involved. Okay.
Dr. Shih.
Okay, great, thank you. And so reiterating what you've heard, we work together as a team of physicians and other healthcare providers. And so deciding on radiation therapy is very much looking at everything that has happened up to this point, the scans that you saw, the extent of surgery, the pathology, but it's very much about the person. So I don't make a complete plan. We come in with an idea of what we like to do, but it's until I see the patient, I see how they're doing, integrate everything else that's gone on that you heard Dr. Gilbert first describe, like all the stuff that happened in life before the time of this diagnosis, the rest of their health, because stamina is everything in radiation therapy. Once we make that decision to move ahead with radiation therapy, what I'm presenting you here is a pretty standard pathway in terms of radiation treatment, but there's actually a lot of different nuances, different ways we set up patients, different technology now that can target radiation to where we need it and really eliminate a lot of the excess radiation. So if you know someone who got radiation 20 years ago, even sometimes 10 years ago, and they did not have a great experience, that isn't necessarily the course it is today. I think we can do much, much better. And for this case, on the left, you can see, go back, a mass. So to deliver radiation treatment, this is specific for a brain tumor patient. We want to make sure that it's daily treatment, Monday through Friday, 5 days a week, and it can be any number of treatments. Some other diseases that we treat in the brain can be as simple as one treatment. For this, we're going to talk about a standard course over 6 weeks. We want the person to be in the same position each day because our radiation beams are designed to be only as big as they need to be to treat the area of interest. And so we have a mask that you see on the left. It's a plastic mask. The sheet you see on the left, that's what it's like when we get it from when we purchase it, and it's what we call a thermoplastic. We heat it up. Once it's warm, it stretches, and they can see it on the right there on that left picture still. So it stretches like a little bit like Play-Doh over the person's head. If we treat a different part of the body, it'll be the shape of whatever area that we're treating. You can see it's a mesh. You can breathe through it. You can technically see through it. Most people keep their eyes closed. If you like, Margaret Gregory, who's a radiation therapist and has her own display out at ABTA today, this conference, has the mask. You can actually feel and see what it's like. And those are the patients who've been through this know what it's like, but this is, I think, very informative for your loved ones. And then we do a special CAT scan. Sometimes people are like, oh, I've already had a CAT scan. This is a special CAT scan with you in the position that's comfortable for you that we can replicate every day for radiation treatment. The scanners are set differently, so we understand the density of the scanners. They're different from the diagnostic scanners that the radiologist will read because they're specifically set to optimize for radiation treatment. And then there's a lot of behind the scenes from the point of me seeing a patient, deciding and agreeing that radiation therapy is in their interest. They go through a radiation planning session like this, then you go home, and then I get to work with my medical physics and dosimetry team, and we create a plan that looks like this. This is representative of it, where we integrate the different kinds of MRI scans before surgery, after surgery, and actually you can see an example here on the left is that T1 with contrast, and in the middle was the T2 flare that we were talking about. It's also very important. And then on the right is the CAT scan that I do for radiation planning. And then I work with my physics team to create a plan where we can get the highest dose in orange to the area of interest. And this is one of the points of confusion. Sometimes patients come to me with, like, well, my surgeon told me he took it all out. The radiologist agreed, so what are you treating? There's the tumor that we can see on a scan, see in an operating room, but we know for this type of tumor, inherently there's microscopic cells that invade the surrounding brain, and we don't want to cut too much into that because that's actually normal brain tissue, and it goes back to what we want to preserve function. We don't want to create deficits to get every last cell out, tumor cell out. So that's where the radiation and chemotherapy and other new medications are targeting, and that's what you see here. And so it's not perfect in the sense that you get the high dose radiation where we want it in orange, and then you get the other shades of colors there, and that's the lower dose radiation that peters out. And that's also really important to make sure that low dose radiation is safe, it doesn't cause more side effects or deficits, and that's where it's a very iterative process. This planning process usually takes between 1 to 2 weeks in most centers because I work with the physics team. It takes them a few hours to run a specialized software to create these personalized treatments, and then we'll go back and forth and we negotiate like where we can send that lower dose to get the high dose where we want. We meet with you weekly. Patients are here every single day, Monday through Friday, for their treatments. They meet with the radiation therapist for their treatment, and then I, as a physician, and oftentimes through a nursing team, will meet with them at least once a week just to check on side effects and symptoms. You don't feel radiation. So on one hand, it's super easy to get, sort of, but it's also scary when you can't feel something and see something to know exactly what it's doing. I don't know if we have the time, but we can go more outside of the session, but like common side effects for this kind of treatment is going to be like fatigue, hair loss are going to be the big two, loss of appetite.
That fantastic overview. So 2 points. The first, the thermoplastic is very expensive Play-Doh. And the second, you mentioned on a more serious note, the patient's functional status. So if this person, instead of being 61, was 75, what would your approach usually be?
Yeah, so radiation seeps from the stamina. So in the first week or two of radiation therapy, many times patients are like, I don't feel anything, I'm doing great. I'm like, that is great, but actually secretly it is taking away from stamina. You don't have as much reserve. And we know as we advance in age, or if you just have other medical problems, that your reserve is less. And so what we do, instead of doing a 6-week course of radiation treatment, we have shown studies that you can actually condense it over to 3 weeks, and people tolerate that much better. 3 weeks is like a magical time of like, most people can tolerate 3 weeks. Going above that requires a little bit more reserve, and so we'll do a more condensed version for people who are, we think will have a struggle going through 6 weeks.
So Dr. Sharma, we have a radiation plan. What's your plan?
So my plan is to combine this with chemotherapy. So oral chemotherapy daily, every day, Temodar. And this is discounting if a patient was not qualified for any trials. Most trials for glioblastoma right now are going to include radiation therapy because that's the standard of care. But as Dr. Shih mentioned, the person is most important. So before we have the tumor board, we've ideally met with the patient and we've figured out what's important to them. I think we go to the next slide. And what are the issues that we need to consider? And our nurse navigator is very important in that journey, is to kind of think about what else is important that we need to take into consideration as we make the plan.
Eva, you're on.
Thank you, Dr. Gilbert. So now we have a treatment plan for this patient, right? We have chemo and radiation. What next? How can we make sure this patient is supported, make sure that they're successful in this, getting this treatment? just kind of giving you a bit preview again back to our case. So our patient is a 61-year-old male. He's retired from law enforcement. He's newly divorced. He doesn't have any kids. His father passed away. And he lives about 45 minutes away from home. So what type of social support does he have? We understand that this diagnosis is very challenging. We want to make sure that he is supported. So does he have any other, family, immediate family nearby? Does he have a community support? What about the law enforcement community? So those are some things we need to start thinking about for our patient. So if, let's say, this patient does not have that, which would be unfortunate, is it safe for this patient to go to this treatment? He has to go there, right, Monday to Friday for 6 weeks. Can he do that? So we understand that radiation can also increase the risk of patients developing seizures. So we want to be mindful of that as well. We would want to collaborate with our social work navigators as well to see, are there any sort of transportation services that could be feasible for this patient. So there's an organization called American Cancer Society. They do have what is called a Road to Recovery program that offers these free rides for these patients receiving cancer treatment. So we'd want to kind of get them touch base and scheduled with them. Some other things we want to consider is, again, this patient is retired. So what source of income does this patient have? What type of insurance does he have? Does he have state Medicaid? This is also related to clinical trials, right? And enrollment and everything if he's looking outside of the state as well. Has he applied for Social Security disability? Does he even understand what that is? So with the GBM diagnosis, thankfully, it does give you a faster approval because it's part of the compassionate allowance list, but this patient still have to wait 5 months before they even get benefits. So what savings plans does he have? Does he have anything on board? The ABTA, they do provide a great financial assistance resources. I know they believe they have the Glenn Garceland Fund, which is based on funding availability, but they have an array of resources on their website that provides other organizations that can provide this. And the other thing, the theme that everybody's talking about is clinical trials. So we want to assess and educate. Does the patient understand what a clinical trial is? Do they know their patient's rights? Do they understand when is a good time for them to be eligible? We also, as the theme, they're talking about biomarker testing. Has the tissue been analyzed? Do they understand what that means? So there could be potential targeted therapy for this patient. And then also talk about what potential treatments that may exclude them for future trial opportunities. So we want to present that and educate that. And then also notifying about, is there any trial available closer to home for this patient that's more convenient, so we can also help assist.
So these are all things we do discuss in tumor boards on a regular basis to try to keep in mind, like, what is the big picture and who is the patient? Are we making the best care for the patient? We also sometimes have patients who don't want to do radiation, and so those are some of the controversies that come up. Or Dr. Shih, I want to ask you, if this patient was 21 and I referred them to you, which I did a few months ago, a patient, how would you talk to them about protons?
So proton radiation therapy is one of the newer technologies out there, and it can sometimes be beneficial. It depends on the diagnosis and the patient and so forth, but what the general principle with proton radiation is a radiation beam that stops where we ask it to. Unlike regular radiation beams, which are high energy X-rays, it just passes through. The highest dose is in the beginning of the beam, and then it peters out. And most of that low-dose radiation in a normal beam that peters out doesn't really cause any long-term side effects in adults. But in children and young adults, that low-dose radiation can have a greater impact on things like neurocognitive function. That's where proton radiation, because that beam stops, can be more helpful. The resource of protons, there's about 50 proton centers around the country right now versus several thousand of regular radiation treatment machines. And so it is still a limited resource, because you could say, well, couldn't everyone get protons? Theoretically, but we just don't have enough to go around, and insurance is an issue also. But that would be someone we would consider for proton therapy, a young adult.
So just for clarification, so that people don't feel like if they've gotten photon radiation, that photon radiation is actually the preferred treatment for glioblastoma.
It is, yes. And photon treatment is actually, and I oversimplified it by saying the radiation beam stops with protons. The ability for us to even manipulate photon radiation and even the safety technically of the beam, we understand it so much better. So it's still the preferred treatment for the majority of adult patients.
And I asked that question for that reason. A lot of time patients come to me and say, I really want to wait for protons. The goal is really to get you started on treatment, and we have no evidence to suggest that in glioblastoma, protons are better than photons. So we really want to get you started on a trial or a treatment. We don't want to have any other hurdles or delays in care. We want to start within 6 to 8 weeks of surgery.
Okay, so let's go back to this patient. Evalu's done a magnificent job. You organized, helped the patient. 6 weeks of chemotherapy and radiation. Patient's seen a month after. Everything looks good. Akanksha, what do you do?
Yeah, so this patient did not do a trial, and so I did the standard of care treatment. And what that means a month after is that I'm going to now start them on adjuvant chemotherapy, or 5 days a month chemotherapy. Sometimes I have to make adjustments. If the patient's stamina is not good, then sometimes I go to different doses, or lower the dose or adjust the dose based on their labs, their tolerance, and how they're feeling. I also have a conversation with them about Optune, or tumor treating fields, that usually starts a month after, although we're waiting for results of the Trident trial that just finished. But we try to get all the important treatments started about 3 to 4 weeks after the end of radiation. We're giving the brain a rest in those 4 weeks. And as Dr. Shih mentioned, it's incredibly fatiguing. And so we try to let you recover before we go into this adjuvant treatment. And the adjuvant treatment is going to go on for 6 months. We used to have arguments in tumor board about 6 months and 12 months. And now we have more data to suggest that 6 months is equivalent to 12 months in glioblastoma without as much toxicity. So we really try to do 6 monthly treatments of Temodar.
Okay, fantastic. So the patient's gone through all of that. We're now about 15 months in from diagnosis, and we have a scan that looks like this. So Javier, you're on.
All right. So this is more what we deal with day to day and the challenges that we see in tumor board and what we talk about as a group. This is a series of scans from the time of initial surgery. The one on the left side of the screen is the immediate post-operative scan we were looking at earlier. And then we have some images that were acquired after the completion of radiotherapy, and then following that. You can imagine that as we look at the scan in the middle at that time point, we'd be a little bit concerned. We see some increase in that contrast enhancement that we had said, hey, you know, our neurosurgery colleagues, they got it all out. Now we see contrast enhancement again. What gives? Is this tumor that's growing back? We know these are aggressive tumors. We discussed how there's a lot of microscopic disease in these cases. Is this tumor that's growing back? And what I'm presenting to you, as I mentioned earlier, one of the biggest conundrums we face on a day-to-day basis. And so what are we doing when we're looking at this? Well, we're taking into account the pathology features of the tumor. Is this a tumor that is more likely to show effects of radiation early on imaging, a phenomenon we call pseudoprogression? Are there additional sequences? I mentioned earlier the bread and butter sequences, T1 post-contrast and T2 flare. There's about 10 or so other sequences that we can and often do acquire when we're acquiring imaging in our brain tumor patients. And this is something that I would recommend across the board is if you're getting scanned, you're getting loved one scanned, make sure that the protocol that's being performed is a brain tumor protocol, because it will often include these other sequences that we use for troubleshooting that help us understand the cellularity, help us understand whether or not there's blood products, whether or not there's elevated blood flow. All of those things help us make a decision. In many cases, though, we're still left scratching our heads. And we may say, you know, we need to do a short interval follow-up scan. And that's what happened in this patient. We did a short interval follow-up scan. You can see the contrast enhancement subsided. And given the timing, the features of this tumor, this is a case of pseudoprogression and something where we can have a good hunch up front, but it's not really until the follow-up imaging that we can confirm that. And that's what we're seeing here.
Dr. Lim?
Can I just make so this is where the molecular imaging is so important. As an example, we listed a whole bunch of markers. If the person had what they call MGMT methylation, if this happened soon after the chemo and radiation is done, we know from the biology this is more likely what they call pseudoprogression will probably disappear. Whereas if you had an unmethylated tumor, we're more concerned that the tumor is back. This is where the tumor board really makes a difference. All the people are together to look at that. And as Javier mentioned, we could look at things called perfusion. I mean, you call it the hunch, the gut sense that we can say, well, it looks like it's probably just going to be pseudoprogression and we're going to ride this out. Whereas we may say, this looks like tumor, and I may say, well, that looks like something we can take out. We can get at it pretty easily. And if you were in an unmethylated tumor, this is differentiating between being aggressive and not. And all these little subtle things that we just mentioned, all this stuff, this is where the tumor board really makes a difference for the patients.
Right, so it's really achieving that consensus and recognizing that you can look at an image, and that image on the far right could be what we call radiation effect or necrosis, or that could be tumor. And you take all the clues that you have, how's the patient doing, and what people are thinking. Now, the only way to know for sure is to actually sample it. But that's not a trivial decision, right? That's a neurosurgical procedure. And oftentimes, though, it does resort to that. So, Dr. Lim, to put you on the spot, which is my intention, if the tumor board said, you know, we're kind of on the fence and we don't really, if it is tumor, we really want to get on top of it, what would you do in this circumstance?
Yeah, so in this situation, again, this is where the tumor board is so important, because the question I would have, the question for me is, can you get at it? And the answer is, again, I think I can get at this without compromising someone's quality of life. The surgical data on getting it all out is a little bit controversial. I personally think in situations where it's discrete, you can help and affect survival. But the data is not so clear on that. But the goal is to get a diagnosis. But the other important part is the trials. Now there are different trials that are out there. As an example, they call window of opportunity trials are happening across the US. That is where if you think you're eligible for a trial, they give you the drug before surgery, and then the patient goes to surgery and we take the specimens out and we can actually try to see if the drug is doing something. Another set of trials that are out there is the CAR T-cell trials, as an example. We're doing those, but we actually put little catheters and reservoirs into the patients so that they can get infusions of these drugs. This is, again, where the tumor board is critical, because they know all the trials that are going on across the country. Getting in there and sampling is just one part of the reason for going for surgery at this point for this patient.
Right, and I think the point to emphasize is that if you put this patient on a clinical trial and it turns out this is not true progression, they're not going to respond. And you're going to say they failed treatment. They haven't obviously failed treatment. You're not going to make necrosis better with treatment, but you're then compelled to try another treatment. And you can imagine going down that path, and then in reality, you started off with the wrong premise.
If I can make one quick comment. So the standard of diagnosing recurrent disease right now, it really is getting the tissue, but there's a new things on the horizon, so-called liquid biopsy, which we and others are pioneering. And what we are hoping is we're going to be able to detect how the tumor is responding to the treatment. Is it recurring? Is it the same clone? Is it a different clone? Hopefully with the minimally invasive techniques, using so-called liquid biopsy, where we can detect glioma, DNA, mutations, clones directly from the fluids, either from the CSF, which, it is not completely non-invasive, but it's less invasive than the surgery, and hopefully in a not too far future, directly from blood, which would be really minimally invasive. So that is hopefully the future, how we can track this disease and answer some of these questions better.
Can I make one other?
Of course.
So the other thing that's critical is you want the second specimen to be read by a neuropathologist. I'm not trying to be biased, because it is not a binary answer. Oftentimes, the pathology report, you'll see in these journeys, sometimes they'll say, lots of necrosis, small foci of active tumor. And then you say, what do we do with that? And this is what the tumor board is, because it's not always just all active tumor. A lot of time it's a mixture. And it's so critical to, again, have the tumor board and a neuropathologist involved in this part.
So putting Dr. Snuderl on the again, in the spotlight, what do you do in your pathology report? What are the criteria that you use to distinguish between what looks like predominantly reactive tissue or necrotic or an active cancer?
Yeah, no, so these are often not easy questions to answer because, as Dr. Lim pointed out, it can be a mixture of both. And we expect a mixture of both because radiation will always destroy some of the tissue there. And it's sometimes very difficult on that, as I showed you that histopathological slide, to distinguish between, normal cells also don't like to be irradiated. So once you irradiate them, they start looking weird. Right? So then you're looking at a section when you have a lot of necrosis, you have some cells that are there, but they don't look completely normal, but you're not sure, and then you use a variety of tools, either immunohistochemistry, but now more and more preferably molecular pathology. When you analyze the sample, and you can actually prove definitively, are there tumor cells in the sample, and most importantly, what is the fraction? Is there a teeny tiny amount of cells, but majority of the cells we sampled are actually normal, or is majority of the cells in our sample that neurosurgeons like Dr. Lim send us actually malignant, which would indicate a true progression?
Yeah, so again, it may seem like we're spending an extraordinary amount of time on this point, but for those of you who have gone through this journey, this is one of the most important and difficult questions addressed by the tumor board. Look at an image, hear about how the patient is doing, because their clinical function does weigh heavily in this decision making, but then how do we make that decision? How important is that decision? How essential it is to get the right answer, right? And so that's going to lead us to our next slide.
Yeah, I don't know if we have time to get to our next case, but I did want to add to this that this is why, based on what everybody said, it's important to this is a time to get a second opinion. So as you can feel, like this is a lot of experience-based feeling. There's a lot of different people. And so especially if you're in a hospital that didn't have access to a neuropathologist or neuro-oncologist, this is the time to get a second opinion. And this can be not just for glioblastoma. That's our second case, was a low grade, but pseudoprogression comes up with all gliomas. You will?
We will get there. We have 30 minutes.
They restarted.
Yeah, they gave us 2. Yeah, don't worry, I got it.
I was getting stressed out.
This is not my first rodeo. Okay, fantastic. All right, so Javier, just take us through this.
I can quickly comment on this. So here, this was a slice a little bit lower. We were following this patient over time. The image on the left-hand side of the screen, that was some time in the follow-up, and then the right side is the current time. On the right side one, we see a growth, a little focus of nodular contrast enhancement that you can see again on the right-hand side, a little bit kind of in the middle of the screen there. That was something that we deemed to be true progression, and I want to maybe use this example just to comment on a little bit further on some of the challenges we have with imaging, right? We may see this and we may also be scratching our heads. This person may be out of the window of what we would consider typically pseudoprogression, which is in those first 6 months or so after completion of radiation therapy. They may be a little bit further down the line, as we had said, maybe 15 months out or something like this. And we're still always, there's the question of, could this be radiation-related effect? But we're looking at those other sequences that I mentioned, like perfusion, for example. If you see that this thing has elevated blood flow, that is suspicious. And then it gets to, then it goes to our surgeons to say, okay, is this something that you may be able to resect? We've talked a lot about MRI, but I think it's worth noting that there are some additional imaging tools that we may employ at this time. You may have heard of molecular imaging with PET or positron emission tomography. The most commonly used imaging agent there is FDG, or fluorodeoxyglucose, which is a glucose analog. It's normally taken up by the brain, so it's not the greatest way to query lesions in the brain. So as a result, we use other agents like amino acid radiotracers. These are widely used in Europe and other parts of the world. It's not something that's routinely available in the United States. there's a big push to try and get these agents available for our patients, and many of the specialized brain tumor centers do offer something like this. And this would be the time point where we may say, okay, before we make the commitment to go on to surgery or additional treatment, let's get some greater specificity, let's get some greater confidence, and that's when we may choose to do those types of imaging exams.
Fantastic. So again, this is the most important and complicated part of the tumor board discussion. So let's just quickly review. So Dr. Sharma, as the captain of the team, do you want to just
so we
review
are
this?
watching your scans closely in this post-treatment period, and that's when we start seeing the changes. And we might present it at the first change, or we might say, okay, we feel pretty comfortable because you're clinically doing well, and so we'll keep watching it. But at some point, we're going to coordinate referrals back to neurosurgery, and this is an important time to talk about and lead conversations on prognosis, and also to talk preparing patients and their families for what may come, because now we might choose a different clinical trial, we might do a second-line treatment, and we might plan for another surgery, and all of those are very important decisions, and they have to be made with your goals and your values in mind.
Fantastic. But again, keep in mind the patient that we presented here, at this point, we think it's pseudo-progression, so continued observation. And we'll finish up this patient. Evalu, if you want to talk about the psychosocial.
Thank you. So just piggybacking on what Dr. Sharma is saying, the importance of second opinion for this patient. So second opinion is really important, and we encourage that for patients if they feel that they're, questioning about their treatment plan or wanting to reach out to other centers of excellence. Again, maybe another brain tumor board panel can take a look at the tumor tissue and analyze it to make sure it really is what the diagnosis. So the ABTA, they do have a great brain tumor treatment center finder if you haven't looked at it yet, and they provide a list of centers of excellence across the nation. And then here at BTN, we can also provide these services for our patient. So just a little plug, thank you, ABTA. But Brain Tumor Network, we're also a nonprofit. We work well with ABTA. And we provide free, unbiased, evidence-based navigation support to any patients diagnosed with a primary brain tumor, whether that's adult or pediatrics. So our goal is to basically be that complementary support to the team that you already have, whether that's exploring second opinions, getting you referrals to other centers, helping you collect and transfer your records for you to help expedite those. We can also help perform clinical trial searches. So as we talked about, different time points of eligibility. So now if this patient were to have a recurrent, so those trials will be different from newly diagnosed. So we can help with that as well. And then we can also, we have social work navigators that provide psychosocial support. So if you need emotional support, education about Social Security, disability, insurance, location about financial resources, we can do all of that as well. So again, we're here as a complementary support to make sure that you're fully guided along your treatment plan. As Dr. Sharma mentioned about advanced care planning, so we're a year and a half in for this patient. We want to make sure that his goals and wishes and values are honored. So we want to make sure that he's got his advanced directives already filled out. So those are legal documents. We have power of attorney, living will. We want to make sure that he has a person designated to make sure that his honors and wishes are fully supported as he moves on to the treatment. And then again, for the patient-centered and also for the caregiver we want to make sure that they're aware of any support groups and peer mentorships, and ABTA has an array of that, and also there's a lot available in person and virtually depending on each local centers. We understand that this diagnosis again is very heavy, it's very overwhelming, and not only affects the patients but also their caregivers. So we want to make sure that we have a lot of resources available for both of them.
Great, thank you. Dr. Lim?
Can I just make one? Be prepared, though. If you get a second opinion and a third opinion, you maybe get 3 different opinions, okay? And I think what to do with that at the end, it can be confusing. That's why we have these resources that are mentioned here. I think what's important, though, in this journey is that I think you have to, you as the patient and you as the family have to decide what is it that, do you want to be aggressive at this point? Do you not want to be aggressive? Are you tired from the surgery and the radiation? These are all important things that you have to have in your mind as you get these opinions, because there are aggressive places and there are places that are a little bit more passive and wait. In this person's scan that we had done, let's say we waited and the tumor doubled in size. It's not like, I don't think the cat's out of the bag for that patient in terms of, I think all of us would agree with that. But some people who want to be as aggressive as possible and say, I just can't sleep knowing this is there, being aggressive might be the right answer for that person. And so again, as you go through this, when you get multiple opinions, be prepared to get multiple options. And there may be 3 very different ones. And I think it's very important that you define how, what your goals are as you go through this.
I think that's an outstanding point. So over the course of my career, I took care of over 5,000 patients. And I felt the most important thing was at each decision juncture, we made the decision that irrespective of the result, when we looked back, we had no regrets of the decision that we made. And that's a really, really difficult, but such an important point. And I think the benefit of a tumor board and experts like we have here on our panel is they will tell you what the various options mean, so that each person can make the right decision for themselves. There is no one right decision. If we knew how a treatment would work, we wouldn't actually need to see people. We could dial it in. If we knew it didn't work, we wouldn't do it. If we knew it worked, we would just do it. And so I think those are really important. So, and I hope you get a sense from this first discussion how important conversation is, discussion, and consensus. So with that, we'll segue to case 2, which is a little, I think it's going to be a little briefer, has to be. We have 20 minutes and 33 seconds left. But you guys have all heard the way this works, so we can actually go through the various components a little quicker. So it's a 32-year-old left-handed woman presented with progressive right superior visual field deficit, and as you will see, a large left temporal insular lesion, previously healthy, active, only has hypothyroidism, notice some jerking of her right arm, recently engaged with a wedding plan, an attorney, busy law firm, emigrated to the country from college, parents, so we're thinking support, they live in China. So Javier, a little more briefly, but
Yeah.
There you go.
Absolutely. So what I'm showing, or what we're looking at here, is another axial image. So from the top down, this is a T2 flare sequence. I know on the last case we looked at T1 post-contrast. I just want to make clear that when we're looking at the imaging, we're looking at all of the sequences for every patient. We're just pulling out the ones that we think are relevant for the discussion here. So here we have T2 flare. We see some bright signal and some expansion or mass-like growth of the left temporal lobe. T2 signal hyperintensity is that bright signal that you're seeing. It's also fairly nonspecific, and it can represent tumor or swelling. Edema is what we call it, or swelling. It can also represent scarring in the post-treatment setting. This patient has not yet been treated, so we're not necessarily concerned about scarring or gliosis. But the challenge we face is determining or defining what is the edge of the tumor. Where does the tumor stop and just edema or swelling kind of begin? One additional thing I'll point out here, looking at this, in addition to that swelling, is kind of the internal aspect. Looks like there's some dark areas. It's got what we would call some heterogeneity to it. So, you know, I'm looking at this and I'm thinking, this looks to me like it's an IDH mutant tumor by imaging characteristics. I can tell you I don't have the contrast enhancement up here, but let's say it's not enhancing, so I'm thinking it's probably a lower grade tumor. But that's kind of where I would stop. And as I mentioned in the other case, one of the critically important roles of a neuroradiologist here is to also identify additional sites of disease, because that's gonna be critical for management.
So that's fantastic. So this is actually where our neurosurgical colleagues shine. And this is, you're going to hear why it's so important that the person who does the operation is a skilled brain tumor neurosurgeon. So Dr. Lim.
Yeah. Could you go back to that picture?
Of course.
So I think at this point, again, the principles of getting as much as you can out, is critical for this type of diagnosis. For low-grade gliomas, the data seems even clearer. The more you get out, the better the patients can do. And what we have right now, where the field sits, is if you can get at least 75% of it out, patients can live a pretty long time. Now, that's a nuanced conversation because 25% of a bigger tumor like this is still a lot of tumor, whereas 25% of a small tumor is a very small residual, and that's kind of where experience comes in. In this situation, again, the principles are to try to get as much of it as you can out, and there's actually a new principle in this. We call it GTR plus, gross total resection plus. We actually get a margin of almost normal brain out. And when you do that, some of the patients can do really, really well. I mean, decades, if you can achieve that. For this person, it's a dominant hemisphere lesion, we think, which means speech is probably in or near it. And in this situation, I'll have a patient go through what's called a functional MRI. You'll get an MRI, you'll be asked to talk, move your fingers, and we'll be able to map out where your speech is, where your tracks are, where the wires are for movement, and I can see where that is in relationship to the tumor. The tumors can either infiltrate into it, and in essence envelop it, or they can be pushing all those structures away, and that's a critical decision point for me as I plan for surgery. For these, what's different is I will keep my patients awake as we remove these tumors, because I, again, want to achieve as much or get out as much of the tumor as possible. And if you look, there are little black dots in that tumor. Those are blood vessels, and we don't want to cause injury to that. And it's critical, again, to be using what I call neuronavigation. We have special instruments that can remove these types of tumors and preserve vessels. And again, having the intraoperative mapping done, which is to keep patients awake. That requires, again, a big multidisciplinary team. I have neurologists in the room, special anesthesiologists in the room to help me do this. But again, the goal is to, even if I could get what's called a GTR plus, patients can do really, really well from that.
So what are the implications of this patient's left-handedness?
So with someone being left-handed, still a good majority of patients have speech on the left side. Depending on the literature you read, for right-handed people, about 90% of people have speech on the left. And for left-handed people, still about 80% can have speech on the left. That functional MRI, I think, is critical.
Fantastic. So this is the post-surgery scan?
Yeah, I'll just mention a couple things here really quickly. So you can see that a majority of the tumor was resected. There still is some residual T2 hyperintensity along the posterior or back aspect, as well as maybe along the medial or aspect along the middle or closer to the central aspect of the brain. And now, I mentioned earlier also that this T2 hyperintensity, it's not specific. It can represent edema or tumor. Now that there's been surgery, we add that additional element of post-surgical change, scarring with radiation, same sort of thing, scarring. And so now you're sitting there scratching your head. What of these three things could it be? And this is where it's important to look back at the prior imaging, understand what was resected, understand the surgical plan, so you can truly say, okay, this here looks like it's, it was there before, so it's probably tumor. We also have some newer technologies that we're applying, some newer molecular imaging technologies where we're trying to understand what's happening in terms of the metabolites present within those tissues. IDH mutant tumors are known to make certain metabolites that are specific to that IDH mutation. So you may have heard of MR spectroscopy, which can be used to help us make that differentiation. There are also some PET imaging agents and some other advanced imaging or MR imaging agents that are being looked at to give us greater specificity, help us understand that. And a lot of this is being driven by some of the newer treatments that you're about to hear from this group.
Great, thank you so much. Dr. Snuderl, you are on with pathology.
Yes, so a lot of same things that I've showed you are shown here as before, but I want to emphasize that it is molecular pathology that really completely redefine how we think about gliomas. We have mentioned the word IDH. Not sure how many of you are familiar with that. It's one of the critical genes that helped us to basically separate adult gliomas into two major categories. For simplicity, IDH mutants, the good ones, if you will, and IDH wild types, which was our first case, the not so good ones, so the bad ones. And what we did here is something very similar. Some of these mutations we can test with the immunohistochemistry directly in a slide, like IDH1 R132H, but it's only one of the mutations that's testable this way, ATRX and P53, and then variety of molecular tests that help us determine how busy genomically this tumor is. You can see copy number profile in this tumor. It's significantly less busy than the previous one, and MGMT is against methylated. I want to emphasize molecular testing is not equally available to every patient at every institution. At NYU, we employ the strategy every molecular test for every brain tumor patient, DNA, RNA next generation sequencing, and the whole genome DNA methylation to really get a complete genomic picture of every patient. And this way we can really confirm not only it's an IDH mutant tumor, which there was a good suspicion based on the radiology, but we can also use some advanced molecular techniques such as DNA methylation classification. As you can see at the middle left, it classifies an IDH mutant lower grade. And that is very good news for these patients because we know now molecularly that these patients are truly lower grade by molecular techniques, not only based on the microscope.
That's fantastic. So I want to really emphasize a point. So for IDH mutated tumors, the staining, which you see on the second panel from the left, will only be positive in 90% of IDH mutated tumors. Okay, we call those canonical. So you can impress people at, parties. If you have one of them, you have a canonical IDH. If you have one of the other 10%, you have a non-canonical. You cannot diagnose an IDH mutation in a non-canonical mutation with staining. That requires DNA sequencing. So if a patient has a tumor and the pathologist says the IDH stain was negative, this is not IDH mutated, there should be a buzzer that goes off. What did the DNA sequencing show? I think it's a really, really important point. Doing a stain takes a day. Doing the sequencing has to be sent to a laboratory, et cetera, but it is essential. Would you agree, Dr. Snuderl?
Absolutely. I think it's imperative that every glioma, no matter what radiology or basic pathology says, should be sequenced. Absolutely everyone. It doesn't matter. We have shown over and over that molecular testing is significantly better than pathology estimate of a diagnosis.
Fantastic. So very important message. So in the interest of time, I'm going to pass it on to the treatment team for a quick discussion.
Thank you. So the majority of brain tumor patients in the country come to community hospitals. I am in a community hospital, and so I want to emphasize again for the people in the back, for people virtually, your tumor should go for genetic testing. And these are the cases, the lower grade tumors, where we really see a huge variety based on where you were diagnosed. So if you're in a small town in rural Montana, you may not even have heard of genetic sequencing. You may have had a different kind of surgery. You may immediately have gotten radiation. So there's a lot of variety in treatment. So this is where an opinion, a second opinion, even if it's just virtual, even if it's just tumor board, really will allow you to be on the best treatment that everyone else in the country is getting. So equity and disparity is high in brain tumor care, and especially when it comes to grade 2, grade 3 gliomas, because there is a lot of variety in it, and the research is changing so rapidly, as we'll talk about. And so we really want to make sure you're getting the most up-to-date information and the most up-to-date guidelines are being followed. And so here, this is where a lot of our conversations in tumor board are about, should this patient get radiation? And that'll be a controversy and a discussion. And again, going back to who this patient is, what's important to them. And I think if we go to the next slide, we'll talk a little bit about that. We also discuss clinical trials here. This is very important. Now, I discussed a young woman we presented a young woman who is about to get married. She has to think about fertility. family planning. And for women, it's not very simple in terms of banking. So that takes time. That takes a referral to a reproductive endocrinologist. And so we want to make sure that we discuss clinical trials. We want to discuss fertility, family planning, and then we want to discuss if this patient should get radiation right now, or can we wait on radiation? And some of this discussion comes from very new data from the Indigo trial. So this was a trial done with a drug called vorasidenib, which is specifically targeted to IDH mutant tumors. And so this is our new brave world of targeted therapy, and we're really trying to treat every patient personalized with their mutations. And so vorasidenib in patients who had low-grade, grade 2 tumors, if they did not get radiation, but a year after, if they were randomized to vorasidenib, they had significant control of their tumor, and they also had seizure control. For patients with low-grade gliomas often have seizures. So based on that, we consider vorasidenib for these patients. And again, each patient is individual. It depends a lot on what grade and mutations they have, but we have that conversation in Tumor Board.
Excellent. So, Dr. Shih, you're asked, radiation or no radiation, to be or not to be?
At some point, radiation is usually part of the story for these patients. The opportunity with the vorasidenib is that we have data that shows that it can control these tumor for quite some time. If you only had one option at this fork and said it's either a drug like vorasidenib or radiation, radiation has a longer durability, but radiation has risks of side effects, and going through radiation itself can be arduous and tough. And so we don't know all the right answers there. So what we're doing is taking the data that we have and thinking together as a team, again, as this, the multidisciplinary team, to figure out and incorporating with the patient and family what is right for each individual. We don't really know. We don't have the crystal ball, but we make this decision individualized with each person. If there's concerns that the surgery wasn't that 75-80% that Dr. Lim mentioned, there's concerns from the molecular features of the tumor that it could be a more aggressive variant, then we're more likely to go with radiation, because that's been a little bit more tried and true. And radiation also always comes with chemotherapy. So there's a lot of effects. One decision impacts the rest of the decision pathway. But if a person had great surgery, they're young, they're doing a lot of other things in their life, radiation actually seems really disruptive, and you're worried about always, like, what if there are neurocognitive effects with radiation? Sometimes it may make, right now, for a lot of patients, it's made sense to go the route of vorasidenib if they have the mutation and they're likely to be responsive to this tumor, to this treatment.
So again, emphasizing 90%, it's easy to make the IDH diagnosis by a stain. 10% needs that extra testing, but it's so pivotal and critical in the decision making, not only for treatment, but also for guiding the patient with prognosis. So another emphasis. And so Dr. Snuderl, just to get back, so very important, Dr. Sharma said for grade 2 IDH mutant tumors. So what do? You look at an entire tumor. This was a large tumor mass, and you see it's 95% grade 2, and you see one island that looks grade 3.
Yeah, no, this is a huge point, because people often think that making a diagnosis is easy. You look at a slide, and that's what it is, right? It's quite the opposite. Grade 4s are easy, and I would say the clinical decision there is a little bit easier, because we know it's a bad disease. Grade 2s are usually easy. It's all benign looking or low grade looking. But then there's that grade 3. And it's important to keep that vorasidenib is only approved, I believe, for grade 2. And many of pathologists just don't want to be wrong. They don't want to be wrong in a way, you know what, I'm not so sure. Maybe I'll call it grade 3. That's kind of like in between, right? I cannot be wrong. It's halfway between good and bad. So if it's good, I'm not wrong. If it behaves bad, I'm not wrong either. People hate to be wrong, right? And it's just a human nature. You hedge your bets. And I've been on a passionate quest to eradicate grade 3. I think it's a scourge of our decision making. And we have shown that we can get rid of grade 3 IDH astrocytoma by using molecular tools and really determine this young lady. She has molecular grade 2 tumor. Calm copy number profile, no scary biomarkers. It is molecular grade 2. So even if I see a small focus that gives me a pause histologically, I will not call this grade 3. I will not push my clinical colleagues in the direction of aggressive treatment, because this is molecular grade 2. And we've seen it over and over that even if these patients come back after no therapy, in 90% of the time, they don't have any additional molecular changes. So it would be imprudent to push our clinical colleagues into more aggressive treatment. So I think this is where molecular diagnostics really shines, helps to give you a definitive answer molecularly rather than an opinion based on human feelings.
So, but conversely, it could look grade 2 and the
Absolutely.
molecular look more aggressive, and you would reflect that in your pathology report.
Yeah, you are absolutely right. We've shown that about 25 to 28% in the big academic centers, 25 to 28% of these diagnoses are wrong. Not because people are bad diagnosticians, but because you cannot make these assumptions based on histology. That's why molecular testing is so critical. That's a lot of patients that are either over-diagnosed or underdiagnosed.
So, Dr. Lim, did you?
Oh, I was just going to go back on one point, but the other point of confusion sometimes is, as we mentioned in surgery, I do intraoperative MRIs for my cases, and statistically, 60% of the times when you do an intraop MRI, we actually find there's still a little bit left, and we can get gross total resections or GTR plus. But another question that's also there is, right now, the vorasidenib is approved for even if you get it all out, but that's another one where the tumor board may have another interesting conversation, because even if we get it all out, some will wait and some will treat.
Excellent. So, Evalu, you actually get the last word. In the big picture, the psychosocial considerations.
Okay. Yes, just trying to wrap it up. But so these are the things we want to consider for this patient if they chose, the vorasidenib route. Can they go back to work? This patient is busy. It's an attorney, works in a law firm. Like, what would that look like? Because we want to talk about side effects as well with fatigue, nausea, vomiting, and also elevated liver enzymes. So we want to make sure this patient's being followed up with labs. And just the stress of it all, right? This patient is recently engaged. You're planning a wedding. I remember how stressful it was planning my wedding. So now you're dealing with that and a brain tumor treatment. So that's a lot. And then Dr. Sharma mentioned about family planning for this patient. So, egg preservation typically is not covered by insurance. It's a lot of out-of-pocket costs. We want to make sure, we can present resources of financial assistance for this patient if available, and just provide that mental health and social support for the patient and the fiance as well. They're only 32. They have so much, to go for, and they also qualify for the AYA group, so that's called the adolescents and young adults, ages from 15 to 39. So they are this unique gap, age gap that they have different needs, and they're starting out their career, starting a family. We want to make sure that they have other resources available for them. And there's other organizations dedicated for the AYA group, such as the Stupid Cancer and the Dear Jack Foundation.
I want to make a plug here for my talk later, but I will be talking, sometimes people think lower grade glioma, there's no reason for palliative care to get involved. And so we'll be talking about how palliative care can be a resource for all patients, including and especially patients who are dealing with all these issues that Jenny so greatly summarized.
So with that, we actually went 20 seconds over. I think that's pretty good. I hope you all learned a tremendous amount, those here and those at home, and please join me in thanking our wonderful board.
It's now time for questions. If you are in person, please raise your hand and a volunteer will bring you a microphone for you to ask a question. You can also submit questions on the WOVA app by clicking Session Q&A on the home screen and selecting the Tumor Board session. Please ensure you are submitting your questions under the right session so we can see your submitted questions. We will do our best to get to as many questions as we can with the time that we have, but I do ask that you be mindful with the length of the question that you're asking so that we can get to as many questions as possible. Thank you for your considerations, and we'll get started. What I'll do is I'll ask a question from online first while people are kind of thinking about what questions they want to ask. So the first question that I'll bring up is, how do you decide how to proceed with a treatment for complicated cases? I think we just saw how they go through all of that in the tumor board discussion. But what this person is asking is, does the primary surgeon make the final call, or is it a majority vote final decision? You know, something I think we touched on, but maybe you can
so, you know, having retired, I can say whatever I want. It is by consensus. Most successful tumor boards are by consensus. But it's typically the captain of the ship, which in most circumstances is the neuro-oncologist, who conveys that information back to the patient and family. I'm getting the head bob, so I think everybody's in agreement? Okay, good.
Okay, so I'm coming from the DMG world. So for people who don't know what that is, diffuse midline glioma. And I am seeing more and more people doing re-radiation 3 to 5 times. I'm curious what your thoughts are on that. And then 2 years ago, the very hopeful drug of ONC201 was coming down the pipeline, and now that is being approved. Do you see any hopeful emerging drugs coming?
Okay, so the re-radiation, Dr. Shih?
I'll start with the re-irradiation. So re-irradiation, not just with the diffuse midline gliomas, but any glioma or any other brain tumor, is something that we think about whenever we see a tumor starting to come back, and that basically would bring everything back on the table and say, is there a role for more surgery? Is there a role for more radiation? What other new drugs are there? What are clinical trials? So it is something that we sometimes do, but there are risks with radiation, and the body doesn't, the radiation leaves right away, but the effects of the radiation, there's a little bit that's always remembered in our bodies, and that's something that we take very seriously, because anytime we do a second or third course of radiation, there could be benefit in terms of controlling the spot that you're targeting, but the risks are higher also. So it's a very individualized decision. In general, I try to find a different alternative because I'm worried about the risks of radiation, but yes, we sometimes do it.
Dr. Sharma, talk about what's down the road.
So I thank you for being here. And DMG is often sometimes overshadowed by glioblastoma, but yes, we do have an exciting approval for dordaviprone, and we are excited to look into other treatments for DMG, including CAR T treatment. There's studies going on at Stanford for that. There are other drugs. Now that we have unlocked the key for targeted treatment, I think that's where a lot of our drugs will come from. Now, dordaviprone also kind of works in a targeted treatment with the H3K27M mutation, but even those patients, if we can get biopsies, we want to send for molecular testing. Often those patients cannot be biopsied because of the location, and the case I'll present this afternoon is actually a DMG patient. But in those cases, liquid biopsy, as we discussed, is becoming increasingly used, and again, we can use those mutations then to put them on an appropriate trial. So I'm very excited and hopeful for the future, and I think there'll be a lot more targeted treatments.
Great.
One of the questions that we have from the app, and then we'll get to an in-person, was asking specifically about meningiomas, another type of tumor that we treat. And what I gathered was this was a grade 2 meningioma, so what we call atypical, that had undergone a resection, and there was a small area of growth that they identified, and trying to decide between close observation versus radiation. And if they do radiation, what type of consideration do we give to photon versus proton?
So,
Very complicated question.
so before we jump to that question, Dr. Snuderl, you want to describe? So a grade 2 meningioma is not the same as a grade 2 glioma.
No, absolutely not. Even grade 2 meningiomas, if surgically approached correctly in the right center by the right surgeons, have usually a very good prognosis. Where it really becomes important for pathology is if there's a tumor left behind, and now we have, similar to glioma, additional molecular tools that help us determine how aggressive of a tumor we are dealing with, and that will often help our clinical colleagues like Dr. Shih to decide how much she really needs to go forward with radiation.
Yeah, and I think in interest of time, not to avoid the question, I'm happy to talk to this specific individual or others offline, but it is very complex is the bottom line. If you have a complete resection and things look favor molecularly, we're understanding these tumors better, oftentimes we will not give any radiation, and there are trials that are actually looking at this right now, both here and in Europe. If there is residual disease, as we're mentioning, you can watch it for a while. It doesn't spread, doesn't metastasize, right? And when we think of things like lung cancer and breast cancer, we worry when we see something, it could spread, not just grow where it is, but spread elsewhere. Meningiomas like gliomas tend not to do that. So there is an acceptable practice of watching it, particularly if it's not growing actively, or you can irradiate it. And then radiation has so many options. There is protons, there is photons, there is stereotactic radiosurgery. Each of them has in the information that's been provided, each one of those could be acceptable. It really depends on even more nuances of exactly where it is, how large it is, are there deficits in the patient? And these are all really individualized discussions with the multidisciplinary team, particularly neuro-oncology, neurosurgery also, there's a role to go back and take out the nodule, and of course, is the patient and their family.
And so, Dr. Snuderl, what's the risk of this grade 2 meningioma becoming grade 3?
It's complicated, as everything else we discussed, but I usually like to say if the starting molecular biology of a tumor is low grade, if you don't do anything bad to it, to anger it, it is highly unlikely it will progress on its own and become aggressive. That being said, meningiomas are complicated tumors because even if they're histologically and biologically benign, they can simply be growing locations that are impossible to take out. So it is sometimes, I can understand, difficult for patients to understand. I have a grade 1 meningioma and it's debilitating. We see these tumors that infiltrate into the skull, into the soft tissues, into the nasal cavities. So meningioma it can be a frustrating disease. In a way, it doesn't necessarily become biologically malignant, but it can grow through the places in the skull, and I'm going to let Dr. Lim comment on that, where, despite its low grade, can cause an incredible damage to quality of life.
Yeah, I heard someone make the analogy. Meningiomas in general are like Mount Fuji. It's very easy to chop off the top, but you don't always know where the mountain ends. And it's very important that, I think you want to be in the hands of someone who just does a lot of them, because more than ever, you can drill and take out more than you think in certain situations. But there are times where it may be wrapped around an important vessel or a nerve that's responsible for critical functions like swallowing, and you can only debulk. As I said, it goes back to those two principles, quality of life as well as length of life. And with meningiomas, we have multiple modalities that can get people through a long period of life. And I say oftentimes we can get people through where you don't die from the tumor, you die with it, but then it's really quality of life that we focus on.
Yeah, great.
We have a
Great
question
discussion.
in the back over here, too. I just want to.
Thank you. First of all, I just want to say thank you all for your time. This has been really informative. So I'm a patient. I had a tumor resection about 2 months ago, and I have been interested since then in pursuing an immunotherapy out of Europe, which requires a sample of my tumor in order to develop. I have had a very difficult time in understanding where my tumor is located. I understand pathological testing has occurred at 3 different institutions in the United States. And I have not been able to identify how much of my tumor remains, how much of it is unaltered and could be used for this immunotherapy, and how I, as the patient, can identify this information. How can we, as a medical community, create transparency about specimens and also accountability to the patient?
Yeah, I think I can take that. I'm fairly involved with tumor banking at our institution. I think it's important conversation to have, preferably before the surgery, because some of the novel therapies and immunotherapies, they actually require a frozen tumor. Vast majority of the tumors get formalin fixed. They get put in a chemical substance, and that unfortunately alters what we can do with the tumor later on. And for some of the therapies and trials, we need to have the frozen tumor. So a conversation that is really important to happen before the surgery, and I can understand it's a very difficult thing to process, is to have the discussion, what will happen with my tumor? Majority of it will go to pathology, but that's why it's important to be in the large academic center where there are tumor banking infrastructure is in place, so they actually can do it. Most of the big institutions have consenting procedures in place that you consent to part of the tumor being frozen, and as a patient, you always have a right to that tumor first. I want to emphasize that every single banking protocol that I'm aware of, and I sit on a lot of committees, it requires that if the patient wants to have access to that tissue belongs to the patient first, not to the institution. And that is very important to point out. But it's important to be an institution that has the infrastructure, because once the tumor is taken out and fixed, there is no going back. There's a lot of progress. We can do a lot more with a fixed tissue. I dedicated my career to make every single molecular technique being possible on formalin fixed paraffin embedded tissue, because most of the institutions just don't freeze their tumors. But it's important to keep that in mind, that if you are pursuing it, that's something, a discussion to have with the neuro-oncologist, the neurosurgeon ahead of a time is, can I save part of my tumor frozen? Where is it going to be? Am I going to be able to access it in time without spending 2 months filling out the paperwork? And how do I get it where I want it to be sent?
Michael?
I also want to comment, not every tumor looks the same when we open up. Some tumors can be almost jelly-like, and some are very firm and rubbery. And when I take out tumors, depending on where they are, sometimes I take it out en bloc. I say it's like one big mass, and that usually is not an issue for getting samples. But sometimes if it's intricately involved blood vessels, we use this device that breaks up tissue and sucks it up. And literally, if it does that, it goes into this bag, and it's already altered in architecture and change. And it's really not as useful for doing certain tests and certain studies. And if you have a smaller tumor that happens to be more liquidy, it's going to be very hard to get meaningful amounts of tumors for maybe a vaccine. But that also has to be taken into consideration, and that could be also reasons why they have such small samples.
Great.
Thank you.
I have one other question that I want to make sure, and then we'll get to this. Oh, go ahead. Do that one first.
Just quick question. My dad was recently diagnosed with glioblastoma. 2 months ago, he just finished his radiation and chemotherapy, and now currently in his adjuvant chemotherapy. So he was diagnosed with 2 tumors. One is 5 cm, one is 1 cm. They were able to resect the 5 cm in his left parietal lobe. The 1 cm was left behind, and there was residual tumor with the 5 cm tumor. The reason why is because the facility or the hospital that he had the emergency surgery didn't have the right equipment to be able to do gross total resection. But it's supposed to be easy according to other surgeons that has the right equipment. So I guess we also did some genetic, the 400 gene testing as well. So we just found out that he has like one of the most aggressive, I guess, genetic markers, e.g. the EGFR or something like that, and more of them. We didn't test MGMT, so he's basically based in Taiwan, and they don't typically think that MGMT is important, so that's really hard to get. So basically my question is, because he didn't get a total resection and finish a radiation therapy, I was wondering if another surgery would be helpful based on his genetic markers. Second is an option for gliadel wafer is also available if he does the second surgery. Would that be a best path to take, knowing that it could be resected easily, or there should be another, treatment?
So, very interesting question. So you said your father's in Taiwan?
Yes, he is in Taipei, Taiwan.
Okay. So Dr. Lim?
Yeah, I mean, I think not having seen your father's films, there's a lot of nuances to that question. Oftentimes in initial settings, sometimes in a tumor board especially, we'll get patients who've had what we call subtotal resections. And if we discuss in tumor board, if it's recently out from, if they're very recent out from surgery, and we think we can go back and achieve a gross total resection or get them over the 80%. I mean, everybody has different opinions on this. I have multiple, as I talk with colleagues across the country, there's no right or wrong. Our center would be more likely to recommend additional surgery if it's fairly recent. But there's others who say, well, surgery is not the thing that's going to cure, and getting them under chemoradiation is the most important thing. And I think we'll get opinions, both of which are very valid. In terms of gliadel wafers, that is an FDA-approved drug, a device, I guess. And then, but in general, you use it for patients where you think you can get a gross total resection. And so if he were to be getting it as a gross total, if he were to get a gross total resection or there's a recurrence, then technically by the label, he could get that.
So just
but it's a big nuanced
add,
conversation.
Well, just to make sure that everybody knows that there are, in fact, nuances, we're told there's a second tumor. How does that impact your decision-making?
Right, so that's why I was saying I probably need to see the films, because again, if it's a small lesion and it's half a centimeter away and it's in a non-eloquent area and you can get that, then in general, most surgeons would try to get both, at least in the first sitting. If it's another lesion and it's on the other hemisphere, more than likely most of us would probably go for the bigger lesion, understanding that it's probably a more systemic process and there's tumor probably between the two that we can't see, and chemoradiation is critical for that.
Great.
Or the timing of that is critical.
Dr. Sharma?
I was just going to comment on that.
Okay.
We have break in 5 minutes, so we wanted to make sure there was this question we can ask. And that is, if a patient center doesn't have a tumor board, how do they get their case in front of a panel like we have here today?
Yeah, that's a great question, and it's something that we can. So, a lot of places have tumor boards, but they may not necessarily be as well staffed as this one is today. So you want to ask, not only do you have a tumor board, because they may have a tumor board where it's just neurosurgeons or just radiation oncologists. You really want a multidisciplinary tumor board. So who attends your tumor board? And if you learn that it's not, multidisciplinary, or there isn't one, you can do one of two things. One, there are some of these major organizations, major centers of excellence like Memorial Sloan Kettering, MGH, and many others where you can send in your case, your images and everything, and have a tumor board discussion. Or the other path is to have get an opinion with the neuro-oncologist at the facility, and the neuro-oncologist will then present your case at the tumor board. I like that second option because then they get to know and see you rather than just have your films and things. But those are both great options for it.
So, and let me emphasize that tumor board is critical. You saw even these folks, all experts. There was discussion back and forth. And we had selected the cases in advance. And it becomes essential if the diagnosis that is rendered is an uncommon cancer, because it's very common that the diagnosis gets changed by experts. And then many of these cancers, and there are over 130 types of brain tumor that have been identified, many of them you really do require the experts to provide the best treatment plan. So if we're emphasizing tumor board, it's for a good reason. And remember, I came out of retirement to do this, so.
I just want to also comment, even with Congress, they have approved still allowing video visits. And so for people who are in more remote areas and it's hard for you to travel, you can still get a remote visit with a neuro-oncologist, and you can do a video visit, and then he or she can present to their tumor board. And as Dr. Gilbert mentioned, it's part of our standard operating protocol, and I'm sure all of our centers, we want the specimen sent because making and confirming that diagnosis, getting the next generation sequencing is critical for you in making that right decision.
We have one other question right over here.
Okay, thank you. Thank you. First of all, I want to say I find these sessions very informative, and thank you all so much. I know we don't have a lot of time, but I'll try to ask my question really quickly. Say there's a circumstance with a tumor with a gross total resection in the parietal lobe. It was later determined through methylation profiling to be a grade 4 unmethylated glioblastoma, which was thought to be a complete circumscribed tumor. I have a two-part quick question. If there's no recurrence 4 years out, what do you think the likelihood of recurrence would be at this point? And if there is a recurrence, what type of treatment would you recommend? I know that that's a lot. You don't know, but off the top of your head.
Dr. Sharma.
Yeah. So I would ask, especially because it was 4 years ago, I would need to know what the genetic sequencing overall, as you said, molecular DNA methylation was sent, but also the molecular sequencing and what it was. And I mean, so some of the molecular tumors, there's been studies to show that they do relapse slower than traditional glioblastoma, IDH wild type. So molecular glioblastomas will still have a worse prognosis than a lower grade, but not as bad maybe as a high grade glioblastoma. So I'm not completely surprised that the 4 years there's not recurrence. However, it's hard to predict when that recurrence will occur because it's so complicated. It depends on the patient's age, the other molecular factors, as you described, like, yes, it was gross total, but are we sure about that? Who did the surgery? Like, what kind of radiation was done? So I think all of those features are important, but there's really no crystal ball to know when recurrence will occur. However, if recurrence occurs, then we do have a number of treatments, such as based on molecular characteristics, or things like Optune, or depending if they're methylated, like re-challenging with Temodar, doing lomustine, second-line treatments to really try to get control again.
But I would emphasize that if it does come back, it would be really important to sample it again, right? Because a lot can happen in that time frame, and its molecular profile may be very different.
And the other thing is you may want to have that tissue re-looked at. I mean, for example, you didn't mention IDH. If it's an IDH mutant tumor, that could also explain, because there's a new classification today compared to 5 years ago or 4 years ago.
Absolutely. Does that conclude?
Yeah, I want to just thank Dr. Gilbert and the wonderful panelists that we had here today for an amazing behind-the-scenes look at the workings of a brain tumor board. If each of you can stay put, we want to take a group photo during the break, but for all of our audience members, please take this time to have a quick break, and we'll come back for our next session, Managing Scanxiety, by our wonderful co-chair over here. Thank you. If there are any other speakers in the crowd, I see Dr. Dunbar here, but